Hi, my name is Dr. Seth Lucas, and I am a former resident of UCSF. I currently practice in El Dorado Hills, California, and the case that I'm about to present is one that I treated while in residency at UCSF with my supervising faculty mentor, Dr. Earl Johnson. A 12-year, 8-month-old Caucasian male presented to the UCSF orthodontic clinic with the chief complaint of, "I have an overbite," referring to his excessive overjet. The patient had a mild temperament and seemed eager for treatment. His medical history was non-contributory, and he had no known drug allergies. He was receiving regular dental care by his general dentist in San Francisco, by whom he was referred to our clinic. He had no previous history of thumb-sucking habits or other finger habits reported, and TMJ findings were within normal limits. On his frontal relaxed photo, you can see that the patient is grossly symmetric, and facial thirds and fifths are equal and symmetrical. Lips are competent with no incisor display at rest. His profile is convex and posteriorly divergent. Nasolabial angle is obtuse, labiomental fold is deep, and he has a mild nasal dorsal hump. On frontal smiling, we can see that he has a flat smile arc with no gingival display and about 75% of incisal display upon smiling. In the initial intraoral photographs, you can see that he is an early permanent dentition with moderate to severe overbite of 70 to 80%, including slight palatal impingement. His mandibular midline is 1 millimeter to the right of maxillary and facial midline, and no CR/CO shift was detected. His angle classification on the right is a full cusp class 2 molar and canine, and on the left a half cusp class 2 molar and canine with about 6 millimeters of overjet. His maxillary arch form is tapered, and he has mild generalized spacing on upper and lower arches. His lower left 5, his lower 7s, and his upper left 7 are all unerupted. In the models, we can see a moderate to excessive curve of spee in the mandible. In the pano, we can see that the condyles appear rounded and symmetric. The upper and lower 7s are erupting, but the lower left 7 appears to be erupting in a mesial direction below the height of contour of the lower left 6. The third molars are all present and developing. The lateral cephalometric measurements showed that the patient has an increased sagittal jaw relationship due to a retrognathic mandible, with slight compensatory proclination of the lower incisors. In the vertical dimension, the patient is hypodivergent with a low mandibular plane angle. Note the shape of the lower border of the mandible, the shape of the symphysis, and the forward inclination of the condylar head are all signs that the patient has a forward rotating growth pattern. Also note that according to the cervical vertebral maturation method, the patient is in stage CS2 and that peak mandibular growth is expected within 1 year. So, with these dental findings in mind, how would you treat this case given the following options? 1. Growth modification of the maxilla with high pole headgear or cervical pole headgear and full fixed orthodontic appliances or braces. 2. Growth modification with a functional appliance such as a twin block, followed by full fixed orthodontic appliances. 3. Comprehensive orthodontic treatment with a class 2 dental corrector such as a forceps, twin force, or traditional elastics. And 4, comprehensive orthodontic treatment and extraction of maxillary premolars to reduce overjet and achieve a class 1 canine relationship. If you are interested in how this case was treated, please go to the PCSO Bulletin 2016 Winter Edition for more information. Thank you for your time.